I'm so really impressed by this group's enthusiasm and insight. And I think this is exactly what we're here to do. So I'm just really excited about all this work. I'm also really excited to introduce our next panelist because I work closely with both of them, and they are definitely mentors, colleagues, and friends of mine. And they have a lot of knowledge. So I'm really excited that they're here with us today. Um, our first panelist, Melanie Mackinnon, is the head of Ongomiizwin, which is the Indigenous Institute of Health and Healing, Faculty of Health Sciences at the University of Manitoba. Her expertise lies in providing facilitation, research, planning, operational, and advisory and negotiation services that assist First Nations, Métis, and Inuit organizations and governments, and non-government agencies as well, in reaching their maximum potential in health service areas. Melanie, who is originally from Mississippi, I don't know how to pronounce that properly, sorry, Melanie, Cree Nation, remains an influential community voice and advocate within the province. We're so excited to have you here, Melanie. Our second panelist is Dr. Ian Whetter. He is a family doctor and medical education and father of three. He works at the University of Manitoba with a focus on increasing access to high quality, non-judgmental, and anti-racist healthcare for underserved communities. He is the Rady Faculty of Health Sciences co-lead of the Office of Community Engagement, a member of the executive of PGME Truth and Reconciliation Working Group at the UGME lead and the UGME lead for social accountability. He is medical director with Ongomiizwin Health Services and a preceptor with the Northern Remote Family Medicine Medical Residency Stream. And I know these are only a few of the hats that both of them wear. So they have so much more knowledge outside of even what their bios say. So I'm going to open up this. We're kind of doing a panel style format for the information they'll share. So I'm going to open up this first question to both of you. From your perspectives, where are the gaps in primary care the most significant, and who is consistently underserved and faces barriers to care? We've been talking about representing those underserved and marginalized communities. So I'd like to hear what your thoughts are on this. I don't know who wants to start. Melanie? That worked out really nice, Ian.
Thank you, Mandy, and thank you for the invitation to attend today. Nice to meet you all, and really interesting to hear the tail end of the conversation. So appreciate a moment or two to reflect on the work of this advisory circle. So that's a really big question, and as you can all appreciate, as you discuss the healthcare system, it's incredibly complicated, and it's also antiquated. And so, it is an opportunity, I think, through the work that you're all doing to look at how we modernize our health system programs and services to actually meet the needs and be more reflective of the communities that we serve. And of course, our regional provincial community is quite diverse, vast, geographically vast as well. And those considerations also need to be part of that planning framework. I understand that initially there wasn't going to be recommendations or discussions surrounding First Nations, particularly on reserve, as there's a federal mandate, if you will. I just want to plant that seed that there, in fact, part of the Canada Health Act, there is a provincial mandate on reserve, and it's really important in that primary care discussion for consideration. So just the talk around remuneration for physicians, as that is something that Ongomiizwin does within 30 communities in Manitoba and 8 hamlets in the Quebec-Nunavut region. The provincial government absolutely expends fiscal resources on reserve for primary care providers, as well as some chronic care supports like dialysis units. So, Mandy, the question around who is the most, if you can repeat it again, just so I ensure that I have it right as I prefaced probably what I'm going to say next, and Ian and I have the honor and privilege of working quite closely together as well.
So the question was, who do you think is consistently underserved and faces barriers to care?
Well, I mean, it would be the entirety of the Indigenous population, whether you're urban, rural, northern, remote. I think that there are non-Indigenous um, individuals also in those geographical areas that have some specific challenges with respect to equity and access. But I think part of the conversation that I'd be interested in your feedback in or around is what are our assumptions around access? And what does that mean? What does that look like? What does that feel like? And one example that I wanted to share was regarding the vaccine clinics during the COVID response, because it's a really incredible example of how some of us as policy or program designers think about access. So we were really fortunate to negotiate some specific Indigenous vaccine clinics, or to serve, population within the urban area, specifically Point Douglas. And as many of you know, we have some challenges with within our population, within our community, and specifically the precariously housed. And so there was a vaccine clinic that was set up on Higgins, and just not too far away, maybe around 50 meters or so, was an encampment. And the residents that were living in that encampment weren't coming to the vaccine clinic. And so we had some nurses and some docs go out and, promote attending the clinic. And the responses were really, really eye-opening for us. Even as Indigenous healthcare planners, we thought we were doing something that was improving access. But the clients told us that they can't leave their tent. Everything that they own is in that tent. Their whole identity, their whole life. And if they leave it for 30 minutes, it's probably going to be gone when they come back. And that was really eye-opening for us for several reasons, but again, around those assumptions to access. And then the assumptions that we made within the programming or the framing of the programming around the handling of the vaccine, and then pushing those policy umbrellas saying, you know what, we're going to take this to this last mile here. And we're actually going to go to the encampments, and really have to push our policymakers and our government partners to let us do that, because as many of you know, there was lots and lots of rules around the vaccine. But that made a significant difference. And the residents that were in that tent community, 95% accepted a vaccine. And more importantly than that, they actually felt seen and cared for, because we came to them. And I think that's one of the assumptions that we make and have made, is that our antiquated healthcare system has been designed, and I'm saying this in general statements, has been designed to support the providers, not necessarily the patients. And so what that looks like through some of the community health centers, and I think there's some great best practices there that we can all learn from. But one thing that I didn't hear in just the last 50 minutes of your conversation, and absolutely, physicians are a big part of the primary care team, but they're one scope of practice. And I think it's also really important to understand how we can expand, not actually expand the nursing scope of practice, how we can actually have our nurses working to their full scope of practice, because there's a lot that they can do that they're not doing. And we don't even have to change the legislation. The acts are already in existence. So I think that is part and parcel part of, so for example, one for the non-clinician members on the call, my background is nursing and health administration, and all of my nursing has been in remote and northern environments. And in that role, it was considered expanded. So there was a lot that I did with training. So for example, well woman care or well woman checks, and doing PAPs. That is not going to happen in southern Manitoba or in Winnipeg. right? It will with a nurse practitioner, but not with a registered nurse. We're also introducing physician assistants into our Northern and Remote program to be able to extend the physician services, but also be another primary care provider within that context. So I think whether we're in a northern remote environment or whether we're in an urban community, the needs of Indigenous health and access to equitable primary care is imperative for a number of reasons. But as far as the back end of the system that we see is over 50% of emerge visits are Indigenous people in our Winnipeg emergency departments. Upwards of 70% in our pediatric children's hospital are Indigenous kids. And we know through the work of Alan and others through MCHP that the provincial government and the federal government spend twice as much money on Manitoba First Nations on healthcare than they do the average Manitoban. We know that, but our health outcomes are not improving. And in fact, we're getting sicker. So we got a really, really challenging problem. And if we don't address the health of Indigenous people, Manitoba will never have a healthy population. And I think that is not to privilege one group over another, but as our communities grow and our health outcomes continue to go in the direction we don't want them to go or continue to deteriorate, then we need to address that. And I know that was a lot. There's probably other questions. So I'll let Ian also share his insights.
I think you might be frozen at the moment. While that unfreezes, thank you for that. I think you really pointed out a great point about when we talk about access. You know, sometimes we have a lot of blind spots to understand what is access for everyone, because people that for First Nations, Métis and Inuit and other marginalized groups or oppressed groups, it is very different, and it's very amplified, their lack of access for many reasons, as you described, you know, because looking at what are their lived experiences and situations that prevents them from access. It's not always just about actually going to a clinic or having a doctor to click in. It's actually about getting there, right? And what are the things they face by doing that? So thank you. I think that was really excellent. Ian, I'm going to pass it to you to answer your comments on the same question.
Okay, great. I have to apologize. I'm in southwestern Manitoba right now, and my internet is patchy. And when it pauses, it seems to pause for about 3 seconds, and then I'm back. So if I see you all stop moving, then I'll stop talking, and then I'll just resume once you start moving again. So I just want to firstly acknowledge, so I'm a white settler of English and Scottish descent, living, I grew up in Treaty 2 territory, and I now live in Treaty 1 territory. And I think that Melanie's point about the health outcomes for Indigenous people is really critical for those of us in Manitoba. Sorry, are you able to hear me, Jason? I see that you're having difficulty hearing other people. Jason, can you hear me loud and clear? When I don't freeze, that is? Okay, great. And so I think it's important for us to hold that as priority number one, and that we really focus a lot of attention on making sure that that our health services are oriented towards delivering on equitable outcomes for First Nations, Inuit, and Métis people here in Manitoba. So I am happy to know the numbers in terms of the investment, but I think that we are spending foolishly. There's a whole bunch of redundancy in the service, and there are, as Melanie already mentioned, a whole bunch of different types of providers that can provide excellent care that might be more financially sound. But in terms of other communities that are lacking equitable access to care, I think it is important for those of us that are especially in sort of areas where there's concentrations of populations that are not well served by the system, to have a kind of clear idea of how primary care should have the responsibility to deliver service to those communities. And so the other communities that that I would bring up would be, so along with Indigenous, Black and communities of color are not well served by the health system. People living in larger bodies are not well served by the health system. Very often, the chairs in the waiting room and send a signal to people that you're not welcome here. The ability to fit onto the examination table, it often sends a signal to people that they're not welcome here. And even the ways that we talk to people create barriers to access for people, and the fact that we often attribute minor conditions to people's weight when they actually have nothing to do with weight. But that's one of the things that we have a tendency to do in primary care. I think that we have not served well created welcoming spaces for members of the 2S LGBTQIA communities. And I think we don't have to look very far in Canada, if we look back to Wednesday, to see that there is a growing and very well organized movement against members of the 2S LGBTQ community that, you know, comes out of the US. It's got tons of funding from white nationalists, the Proud Boys and the Mothers of Liberty. But it's a real concerted effort to try to make society less welcoming for members of those communities. And so we as healthcare providers have to really double down on our duty to make sure that the care we provide is accessible to members of that community. People who use drugs certainly don't feel welcome in healthcare systems, and the way that we talk to people about substance use has got all kinds of judgment built into it, and we often in healthcare even end up with a very anti-science approach to people who use drugs. We've got tons of evidence that of the ways that we can provide care that is both welcoming and caring, but actually really science-based in terms of the things that make a difference in terms of survival and reduced valvular heart disease related to injection drug use, and overdose deaths from a drug supply that has become poisoned. And I think that we are really challenged to hold the line on the science when there are often political ideologies that are kind of pushing us away from science and towards a way of behaving as healthcare providers that is really anti-science. And so I think we have to hold the line. We're going to be science-based. I think that people who are living with low income have a real challenge in even getting to our appointments in the ways that we schedule them. And oftentimes we as healthcare providers are pretty rigid about the times that people arrive, which if you're a person who is trying to use the bus system in Winnipeg to get to your appointments, the likelihood of you arriving on time is really, really hard. And so we need to have a system that's got room for people to show up 40 minutes late. And if I had a patient this past week who traveled on the bus in his wheelchair to his appointment and arrived like an hour late for his appointment. And I think our response has to be, who cares? Like, you're here, you made it, let's provide you the care that you need. And yeah, it makes the days a little bit bumpy, and that's okay. I think we need to just have lots of room for that in the way that we provide service. I like to say to people that we've got an excellent mental health care system as long as you don't have a mental health condition. And so people, like, the system requires a very high degree of having friends in the healthcare system, having someone who can navigate the system, ensuring that you can show up at exactly 9 o'clock when the doors open for the service that you want to access. And if you happen to show up late, then you're not going to be able to access service that day. And I'm being facetious when I say that. The mental health care system is totally broken. And it needs a major investment, but that investment should occur in primary care. Like, I think we as primary care providers and primary care teams can do a lot more of keeping people well in community. Right now, the crisis resources are totally tapped out, but that's partly because primary care is not meeting the need in the way that we could, and helping people remain stable in community. People living with disabilities, physical disabilities or invisible disabilities, have told us very clearly that their system doesn't meet their needs. And I mentioned just briefly housing, but we need to deliver care to people who are underhoused or precariously housed differently, and need to find a way to liaise more effectively with those housing first initiatives, to make sure that people can be housed, and if they are underhoused, that we can still sort of follow them through their care trajectory. I know very often people get letters for their appointments mailed out to them, and if they've got either precarious housing or fixed address, those letters go into the ether, they miss important appointments, and there's no reason that it has to be like that. We could center your health center as the place where information flows, and then we can figure out ways to find people. And with good connection to community networks, it's actually not like, you can figure out how to find people. Northern communities are the best in my mind at doing that. If you ask the community health representatives at the front desk to find somebody, they can almost always do it. And so I think we also just need to keep in mind that these, because of intersectionality, all of these things collide. So if you are an Indigenous trans woman who is precariously housed, you are going to have way more difficulty accessing care than if you are a white trans woman who lives in St. Vital. And so I think we need to think about the ways in which we've got members of our community who've got multiple intersecting identities that are going to create barriers for them accessing care. And we need to make sure that in that classic equity model, that we provide 3 boxes worth of care so that that person can overcome the barriers that we have created for them, so that the barriers don't live in the person, the barriers live in the way that we've designed the system. Okay, that's the end of my
I think that's really great of talking about how we create a healthcare system and primary care system that is inclusive, not exclusive. We like to think healthcare is inclusive, but it's not, especially to the, like you described, people that have those intersections of oppression tend to really be excluded from our system. So I think that's really important for this group to think about as we do this work, and the recommendations we do. We're going to get to some Q&A right away from the group. I just wanted to ask you about briefly, because I think it's important to understand this, because you touched a little bit about it, Melanie, about the concept of jurisdictional, because we often think, and I think there's this misnomer within Manitoba about how is healthcare funded and delivered from a jurisdictional level, from the federal and Manitoba government, because a lot of the work we're doing is going to be recommendations towards the Manitoba government. So just so if you could really briefly describe, so that we understand what domains, what capacity do we have to make recommendations for First Nations, Métis, and Inuit people.
For sure. Thanks, Mandy. So jurisdiction has been an ongoing debate since the beginning of the Medical Act in the 1950s. And so I think it's important to, and I don't know what the group has been presented with respect to the history of the healthcare system and how it has come to be, but First Nations in particular, and I'll just speak to First Nations, not necessarily Métis or Inuit, as the Inuit have different beneficiary agreements, and the Métis have a different agreement and understanding with both provincial and federal governments. But First Nations status individuals, whether you're on or off reserve, which about 50% of us live off reserve. Oh, sorry, just had some feedback. Can you hear me okay? So have been through treaty arrangements and treaty agreements have been, and actually the language in the agreements, the ward of the state, the federal state. And so up until 1980, well, as of 1984, there were 5 exemptions to the Canada Health Act, of which First Nation status Indians were part of that exception to the provincial, the Federal Canada Health Act and how provincial services are insured, which is a little bit different in each province, but for the most part, similar. Other exempted groups were Veterans Affairs and the RCMP. And so what that meant in the 80s and actually well into the 90s is that Manitoba First Nations, RCMP veterans did not have provincial health cards or Manitoba health cards. So when we went to any clinic, we were allowed to go to whatever clinic or to have diagnostic services or whatever those other insured services are within the CHA. The provincial government would bill the federal government. My former husband was RCMP, and for the majority of our marriage, he never had a Manitoba health card. The province billed the feds for all of his medical appointments. That has since changed with amendments to the Canada Health Act. So those exceptions or exemptions with the aside from veterans is pretty much removed. And now we are all part of the provincial healthcare system, with the exception of on-reserve services, where the federal government still remains responsible for the capital or any kind of infrastructure costs like nursing stations, hospitals, clinics, the employee accommodations, so their apartments, their housing, and then communities have the option to transfer or to take that transfer, but very few First Nation communities, less than a handful, have actually taken on transfer arrangements because of the cost associated and high burden of illness associated with healthcare, and those being unsustainable. And so what you would see in a typical nursing station environment, and there's about 23 out of the 60 First Nation communities, or 63 First Nation communities in Manitoba have these types of primary care clinics, if you will, is anywhere between 3, 4, and 5 different employers of the frontline staff. So the nurses may be Indigenous Services Canada or FNIB employees. The docs may be Ongomiizwin employees or AmDocs or an RHA, like Northern RHA, for example. The First Nation will also have employees in there. And sometimes, like in the case of Grand Rapids, which is where I'm from, so it's Nispausik, and I know it's a hard one to pronounce, Mandy. There's also shared health because of diagnostic services. So, as we've kind of centralized, decentralized our services provincially, we've seen those multi-agency employers in the clinical environment, which makes it really challenging. But also, I think we need to appreciate how the team actually, regardless of those challenges and those barriers and those different jurisdictions, they work and act and function for the most part like a pretty dynamic team on the ground with the scarce resources and the policy challenges that they all have. But provincial government does have a responsibility to providing services on reserve. And they certainly they contract organizations like ours or an RHA to help them do that. And if that community member that lives on reserve needs to access services off reserve or secondary services, the federal government will typically pay for that if they're a status First Nation. But the provincial government pays for all of the acute care costs or the hospital-based costs.